Every 66 seconds, a senior in this country is told they have dementia. By the time this video ends, more than 20 families will have heard those words. What nobody is telling them, and what many of their own doctors have never once brought up, is that for some of those families, the decline was not inevitable. It was accelerated by a medication sitting on the bathroom shelf. A medication that was prescribed in good faith, collected at a pharmacy, taken every single day, and never once questioned. 10 of the most widely prescribed and purchased medications in America have been linked in peer-reviewed research to elevated rates of cognitive decline and dementia in adults over 60. 10 medications. Millions of seniors taking them, almost none warned. Today I am walking you through all 10, counting down from the entry that surprises most people to the one that closes this list. Before we begin, mark this. Watch for number 3. It is prescribed to hundreds of thousands of seniors as a modern, gentle option for depression and anxiety. Most people who take it assume it is one of the safer medications available. The American Geriatric Society's official list of medications considered potentially inappropriate for older adults includes it by name, and the reason it is on that list connects directly to every other medication in this countdown. And number 1 is not what anyone expects. It is not a single medication. It may be the most important thing on this entire list. Subscribe now and help Dr. Mannu Jones reach the seniors and caregivers who need this information most. Before the countdown, 2 minutes on why this matters specifically after 60. Because the same dose of the same medication can have dramatically different effects on a 65-year-old brain than it did on a 40-year-old one. 3 specific changes make the aging brain more vulnerable to medication-related cognitive harm. First, the blood-brain barrier weakens with age. This is the protective filter that normally restricts which substances can pass from the bloodstream into brain tissue. As it becomes more permeable over time, more of certain medications reach the brain directly, at concentrations the prescribing dose was never calibrated for. Second, the kidneys and liver clear medications more slowly. Drugs that a younger body processed and eliminated within hours can accumulate in an older body over days, reaching effective brain concentrations significantly higher than the label suggests. Third, the aging brain has less reserve. A brain at 65 has been accumulating amyloid deposits, losing synaptic density, and producing lower levels of key neurotransmitters for decades. The compensation systems that cushion against interference in younger brains are thinner. The same disruption causes more damage. This is the context for every medication that follows. These are not fringe cases or rare reactions. They are predictable, documented biological responses in a population, adults over 60, that was often not the primary group tested when these medications were originally approved. Let us count down, starting at number 10. Number 10. Proton pump inhibitors, omeprazole sold as Prilosec, esomeprazole sold as Nexium, pantoprazole sold as Protonix, given for heartburn, acid reflux, and stomach ulcers. Among the most prescribed medications on earth. Here is what almost nobody is told when the prescription is handed over. Your stomach requires acid to absorb certain nutrients, and the most critical for brain function is vitamin B12, which maintains the myelin sheath protecting your nerve fibers. Long-term proton pump inhibitor use progressively reduces B12 absorption. So does absorption of magnesium, which neurons require for clean electrical signaling. Starve the brain of these nutrients quietly over years, and you get cognitive symptoms, memory slips, confusion, processing slowdown, that look exactly like early Alzheimer's when the real cause is a nutrient your medication has been blocking. In 2016, a study in JAMA Neurology examined more than 73,000 adults aged 75 and older. Regular proton pump inhibitor users had a 44% higher risk of receiving a dementia diagnosis compared with those who did not take them. What to discuss with your doctor. Whether you need daily use or can taper to the lowest effective dose. Use the medication only when needed or switch to famotidine, sold as Pepcid, an H2 blocker that is far less likely to deplete B12. Also ask for a B12 blood level if you have been on a proton pump inhibitor for more than 12 months. Number 9. Gabapentin, sold as Neurontin, and its related compound pregabalin, sold as Lyrica. These have become 2 of the most widely prescribed medications for nerve pain in the United States, given for diabetic neuropathy, the nerve pain following shingles, chronic back pain, restless leg syndrome, and multiple other conditions. They are prescribed so routinely and discussed so casually that most seniors taking them have never heard a single word about their cognitive effects. Gabapentin works by binding to calcium channels throughout the nervous system, reducing the rate of electrical signaling. That is how it calms nerve pain. But it does not limit its action to the nerves responsible for pain. It reduces electrical activity broadly, including in the brain regions governing attention, short-term memory, and mental processing speed. In older adults specifically, gabapentin clearance is significantly reduced, meaning the drug accumulates to higher effective concentrations than in younger patients. The cognitive side effects in older adults, confusion, memory difficulty, word-finding problems, sedation, and what many patients describe as a persistent mental fog, are documented and dose-dependent. Research published in the British Journal of Clinical Pharmacology has identified cognitive impairment as one of the leading reasons gabapentin is discontinued in elderly patients. Here is the specific concern. Because gabapentin is prescribed for pain, not for mood or sleep, the cognitive effects it produces are almost never attributed to it. The person taking it for foot neuropathy develops memory problems, and everyone assumes it is aging. Nobody questions the gabapentin. What to discuss with your doctor: the lowest effective dose that manages your pain symptoms, and whether topical treatments, physical therapy approaches, or duloxetine, which works through a different pathway and has less documented cognitive effect at typical doses, might provide comparable relief. Number 8. Statins. Simvastatin sold as Zocor, atorvastatin sold as Lipitor. These medications lower cholesterol and reduce the risk of heart attack and stroke. For many people, they are genuinely important. This entry is not against statins. It is for precision about which statins carry cognitive risk and which do not. Your brain is approximately 60% fat and uses cholesterol to build myelin, the insulating sheath that allows nerve signals to travel quickly and cleanly. Aggressive cholesterol reduction with a statin that penetrates brain tissue can leave the brain short of a raw material it genuinely needs. Not all statins cross the blood-brain barrier equally. Simvastatin and lovastatin are fat-soluble and pass into brain tissue readily. Pravastatin and rosuvastatin are water-soluble and do not penetrate as easily. Research in JAMA Internal Medicine found that adults on higher cumulative doses of brain-penetrant statins had measurably higher rates of mild cognitive impairment than those on alternative types. What to discuss with your doctor? If you are on simvastatin and have noticed increasing mental fog or memory changes, ask about switching to pravastatin or rosuvastatin, which provide comparable cardiovascular protection with less documented cognitive concern. Do not stop a statin without guidance. Discuss the type. The heart protection is real and worth keeping. Number 7. Diphenhydramine, the active ingredient in Benadryl and in every over-the-counter product labeled PM, nighttime, or sleep aid. ZQuil, Tylenol PM, Advil PM, Unisom sleep tabs. If the product promises drowsiness and requires no prescription, there is a strong chance this drug is in it. Most people assume that because it requires no prescription, it must be gentle on the brain. That assumption is wrong. Diphenhydramine is an anticholinergic drug. That word matters, and you will hear it again on this list. Anticholinergic medications block a brain chemical called acetylcholine, the primary messenger your neurons use to form new memories, sustain attention, and maintain cognitive clarity. After 60, the brain produces less acetylcholine and depends more heavily on every unit available. A drug that blocks it lands far harder on a 70-year-old brain than a 30-year-old one. In 2019, a major study published in JAMA Internal Medicine, analyzing more than 58,000 patients, found that individuals with the highest cumulative anticholinergic drug exposure had a 54% greater risk of developing dementia. Diphenhydramine is one of the most consumed anticholinergic drugs in the country, and most of the people taking it have no idea it belongs to that category. What to discuss with your doctor? Check the label of anything you take for sleep or allergies without a prescription. For allergies, loratadine sold as Claritin and cetirizine sold as Zyrtec do not cross into the brain the same way and carry significantly less cognitive risk. For sleep, we will come back to this. Number 6. Oxybutynin sold as Ditropan. Given to seniors with overactive bladder, the relief it provides is real. The trade-off almost nobody is informed about is real as well. Oxybutynin is anticholinergic. It blocks the nerve signals causing the bladder to contract involuntarily. But it does not stay in the bladder. It crosses the blood-brain barrier readily and blocks acetylcholine in the hippocampal regions where memories are formed. Among all anticholinergic medications still routinely prescribed, Oxybutynin is considered one of the most potent for its effects on brain tissue. In 2019, research published in the British Medical Journal, examining more than 58,000 patients over age 65, found that those who had taken strong anticholinergic drugs, including Oxybutynin, for more than 1 year, had a 49% higher risk of developing dementia. Risk increased with longer duration of use. The pattern that concerns me most is what happens after the cognitive symptoms emerge. The person begins forgetting appointments, losing objects, losing the thread of conversations. Everyone says it is aging. The Oxybutynin, prescribed for a completely different complaint, is never questioned. What to discuss with your doctor? Mirabegron, sold as Myrbetriq, achieves comparable bladder control through a completely different mechanism and does not block acetylcholine. For most older adults, it is the more appropriate long-term option. Ask specifically, is there a non-anticholinergic alternative for my bladder symptoms? Number 5. Benzodiazepines. Lorazepam sold as Ativan, diazepam sold as Valium, alprazolam sold as Xanax, clonazepam sold as Klonopin. Prescribed for anxiety and insomnia. They work by boosting GABA, the brain's primary calming signal. The relief they provide can be significant, and because the relief is real, stopping them feels impossible, which is exactly what makes them so dangerous for long-term use. Benzodiazepines create a slow chemical sedation of the entire brain. Learning slows. Mental flexibility decreases. Many older adults describe a persistent fog, a feeling of being present but not fully there. In a 2014 study in the British Medical Journal, following more than 8,000 seniors over 6 years, those who used benzodiazepines for longer than 3 months had a 51% higher risk of receiving an Alzheimer's diagnosis. Also worth mentioning here, Z-drugs, Zolpidem sold as Ambien, S-zopiclone sold as Lunesta, work through a very similar GABA pathway. They are often prescribed as a safer alternative to benzodiazepines. For long-term cognitive health, the evidence suggests they are not. What to discuss with your doctor, and this is critical. Do not stop a benzodiazepine suddenly. Abrupt discontinuation can trigger seizures. Tapering must be done gradually, over weeks or months, under close medical supervision. Buspirone can manage anxiety without sedation. Cognitive behavioral therapy for insomnia has been proven more effective than sleep medication long-term, without a single side effect on the brain. Number 4. Amitriptyline, sold as Elavil. This is an older antidepressant that is now prescribed primarily for nerve pain, sleep difficulties, and migraine prevention. Most people taking it are not told it is an antidepressant, and almost none are told what it does to the aging brain. Amitriptyline is one of the most potent anticholinergic drugs still routinely prescribed. It blocks acetylcholine more aggressively than diphenhydramine and more aggressively than Oxybutynin. Because it is often taken nightly over months or years, the cumulative burden on brain memory systems can be severe. In 2015, a major study in JAMA Internal Medicine followed more than 3,400 adults aged 65 and older. Those with the highest cumulative exposure to strong anticholinergic medications, including amitriptyline, had a 54% greater risk of developing dementia. The researchers found that even small daily doses, taken consistently over years, contributed meaningfully to that risk. Most people taking amitriptyline were given it for pain or sleep, and were never warned about its cognitive effects. When memory changes emerge, they assume it is aging. The amitriptyline is never questioned. What to discuss with your doctor? For nerve pain, duloxetine or gabapentin at the lowest necessary dose may offer comparable relief with less anticholinergic burden. For sleep, low-dose melatonin or addressing sleep architecture directly. For mood, sertraline or escitalopram are significantly safer for the long-term brain. Bring this specifically to your prescribing physician. Number 3. Here it is. Paroxetine, sold as Paxil. An SSRI, the same category of modern antidepressant as sertraline and escitalopram, which are considered among the more brain-safe options for older adults with depression and anxiety. Here is why paroxetine is the exception. It is the one SSRI with significant anticholinergic activity. While sertraline and escitalopram have minimal effect on the acetylcholine system, paroxetine blocks it with a potency that places it in the same category as medications we have already discussed. That single characteristic separates it from every other antidepressant in its class, in a way that almost no patient is ever told. A 2021 review in Frontiers in Psychiatry, examining older adults on different SSRIs, found that paroxetine users showed measurable declines in short-term memory, word recall, and attention within the first 12 months. Seniors taking it were 30% more likely to show early markers of cognitive impairment than those on other antidepressants. The American Geriatric Society includes paroxetine on the Beers criteria, the formal list of medications considered potentially inappropriate for older adults, specifically because of its anticholinergic properties. This is not a fringe. Warning. It is an official clinical recommendation that most patients never hear about. The painful irony, it is prescribed to protect emotional well-being. Over time, for some older adults, it may quietly erode the cognitive clarity it was intended to support. What to discuss with your doctor. Ask whether switching to sertraline or escitalopram, both preferred alternatives on the Beers criteria, would be appropriate for your situation. The transition should be supervised and gradual. But for most older adults, these alternatives carry significantly less cognitive risk. Number 2. Antipsychotics. Quetiapine sold as Seroquel, risperidone sold as Risperidol, olanzapine sold as Zyprexa. Developed for serious psychiatric conditions, schizophrenia and bipolar disorder. For those conditions, they can be genuinely necessary. Today, they are increasingly prescribed off-label to older adults for sleep difficulties, mild agitation, or behavioral symptoms associated with early dementia. In nursing facilities, they are sometimes used to manage residents who are confused or difficult to support. In 2022, research published in Lancet Healthy Longevity followed more than 25,000 older adults. Those given antipsychotic medications for behavioral symptoms, many with no prior psychiatric history, were 71% more likely to experience significant cognitive decline within 1 year, even in people who had no dementia diagnosis before starting the medication. These drugs suppress dopamine, involved not only in mood regulation but in focus, planning, and memory. Reduce dopamine significantly in an aging brain, and the person becomes slower, flatter, less engaged. Families often watch this decline and believe it is the disease progressing. In some cases, it is the medication. What to discuss with your doctor or care team. If an antipsychotic was started for sleep or behavioral management, rather than a diagnosed psychiatric condition, ask directly why this medication was chosen and whether non-medication approaches were genuinely attempted first. The lowest effective dose for the shortest justifiable duration is the appropriate standard. Many behavioral symptoms in older adults respond to consistent routines, reduced overstimulation, management of underlying pain, and improved sleep, without a single milligram of antipsychotic medication. Number 1. You were expecting one final medication. The single worst drug on the list. What actually holds the number 1 position is more important than any individual medication, and it explains why so many seniors experience cognitive decline that no single prescription ever gets blamed for. Number 1 is anticholinergic polypharmacy, not one medication. The combination of several, each of which individually blocks acetylcholine at a modest level, taken simultaneously while nobody calculates what the total burden adds up to. Picture a common scenario. A woman in her early 70s takes a Benadryl-based sleep aid every night. She takes Oxybutynin every day for bladder control. She takes Amitriptyline at a low nightly dose for foot pain. She takes gabapentin twice daily. Each was prescribed or purchased separately. No single pharmacist ever flagged a concern. No single doctor reviewed them as a system. Together, these medications are blocking acetylcholine, reducing dopamine activity, and sedating the central nervous system simultaneously, from multiple directions at once. The effects do not simply add together, they compound. In 2022, a study published in Age and Aging tracked more than 280,000 older adults. Those with the highest total anticholinergic burden, calculated by adding the effects of every medication they were taking, had more than double the risk of receiving a dementia diagnosis within 10 years, compared to those with the lowest burden. More than double. From a combination of medications that no individual prescriber ever reviewed as a combined system. Here is what makes this the most important entry on the list. This kind of cognitive decline is often reversible. Reduce the anticholinergic burden, gradually, with medical guidance, and many people regain meaningful clarity, memory, and mental energy within weeks or months. The brain is more resilient than most people believe, but only when the source of harm is identified and removed. Before we finish, one thing I need to say clearly, because some videos on this topic tell you these medications definitely cause dementia and advise you to stop them immediately. That is not what the research shows, and that advice is not safe. What the research shows is association. People taking these medications have elevated rates of cognitive decline compared to those who do not. That association is strong enough and consistent enough across multiple large studies to warrant a serious conversation with your doctor. It is not strong enough to justify stopping a prescribed medication on your own, especially benzodiazepines or antipsychotics, which carry genuine and dangerous withdrawal risks. This channel does not tell you what you want to hear. It tells you what the evidence says. What the evidence says here is, these medications deserve attention, the right questions asked at the right appointments, and in many cases, a supervised review that could change the trajectory of your cognitive health. That is different from panic, and it is more useful. 3 things to do after this video. 1. Write down every medication you take, prescription and over-the-counter. Include anything sold for sleep, allergies, pain, or bladder control. Write down the generic name where you can find it, not just the brand name. 2. At your next medical appointment, use this specific phrase with your doctor or pharmacist. I want to review my total anticholinergic burden. Ask whether any of your current medications appear on the American Geriatric Society Beers criteria. That document is publicly available. You can look it up yourself before the appointment. 3. If you take a proton pump inhibitor daily, ask when your vitamin B12 and magnesium levels were last tested. If you cannot remember, they have not been checked recently enough. The goal is not fewer medications. The goal is the right medications, reviewed as a complete picture, at a dose appropriate for your age and your brain. Every medication on this list was originally prescribed or purchased for a real reason. None of them should be stopped without proper medical guidance. Dr. Mannu Jones is an AI-assisted health educator. Every claim in this video traces to published peer-reviewed research: JAMA Neurology, JAMA Internal Medicine, the British Medical Journal, Lancet Healthy Longevity, the British Journal of Clinical Pharmacology, and the American Geriatric Society Beers criteria. These are sources you can look up and verify. This is educational content, not medical advice. Use it as preparation for the conversation with the doctor who gives you that advice. One question in the comments: which of these 10 medications do you or someone you love currently take? Your comment may be the one that alerts the next person reading it to have the conversation that changes things.